Our next paper is presented by Dr. Yan and colleagues. Dr. Yan's a bioengineer from the Auckland Bioengineering Institute in New Zealand, along with colleagues from the University of Sheffield in the United Kingdom. And she's going to be describing a modelling effect of the bony pelvis on childbirth mechanics. Dr. Yan, please.
Good morning, everyone. I'm Xiani from Auckland Bioengineering Institute. I'd like to thank ICS for letting me present my work on investigating the effect of bony pelvis on the childbirth mechanics using a biomechanical computational model. Childbirth-induced trauma has been one of the leading causes for pelvic floor dysfunction. To understand the cause of such injuries, we need to understand the mechanism of the second stage of labor. The effect of the bony pelvis, the effect of the muscle has been extensively studied. However, the same cannot be said for the bones. So what role does the bony pelvis play? Before answering this question, we need to look at some anatomy. Maternal bony pelvis form the outermost boundary of the birth canal, consists of ilium, ischium, pubis, and sacrum. During the second stage of labor, the fetal head rotates and extends, glide underneath the pubic symphysis, and escape under the pubic arch. In this study, we digitized high-resolution MRI acquired from a previous study to mark the boundaries of the pelvic floor muscles and the bony pelvis. These data clouds were later on combined together from each slice of the MRI images, and the computer model was generated. Realistic skeletal muscle mechanical behavior was used in this modeling work. We are mainly interested in the force required for delivery and the fetal head motion. The female pelvis varies considerably in size and shape. They have been historically classified into 4 types, but each individual can be a combination of 2 or more types. The most common is a gynaecoid pelvis. It has a wide subpubic angle and is considered as the most suitable for childbearing. And the second type is anthropoid. It has an elongated anterior-posterior diameter and is present in 25% of the population. Android type resemble a male pelvis. It has a very sharp subpubic angle and is considered as the least suitable for childbearing. And the last type, platypaloid, has a contracted anterior-posterior diameter and a very wide subpubic angle. So for this study, one representative subject was selected for each of the gynaecoid, anthropoid, and android pelvis. However, we couldn't identify a typical platypaloid pelvis. Therefore, a subject with dimension close to it was selected. 2 computer models were then generated for each pelvis type. One was a partial pelvis and the other was a full pelvis. The 2 most common positions, occiput anterior and left occiput anterior positions, were studied. And the blue lines mark the significant sutures and fontanelles on the fetal head. Here is an example simulation. It's a gynaecoid subject starting with the most common left occiput anterior position. The red graph is the fetal head rotation profile in the partial pelvis model, and the black line is for the full pelvis. The green dot marks the current position of the fetal head in the synchronized movie. So as we can see, incorporation of the full pelvis gives rise to a significantly different fetal head motion at the moment of crowning. Without the full pelvis, the fetal head stayed at the left occiput anterior position, and the full pelvis facilitates the fetal head to rotate to a direct OA position. And we also found that incorporation of the full pelvis gave rise to a significantly different fetal head motion for anthropoid and android pelvis. However, the presence of a full platypyloid pelvis only changed the fetal head motion slightly for the subject that we have selected. So here shows the force required for delivery for the same gynaecoid subject, starting with the same position. Incorporation of the full pelvis gave rise to an 80% increase in maximum force required for delivery for the subject. Similar force increase was also found for anthropoid and android pelvis. And the incorporation of the android pelvis gave rise to the maximum percentage increase in force required for delivery. But the force decreased slightly for the platypyloid type. It's possibly due to the very wide subpubic angle, which imposed little extra constraint when the full pelvis was present. In conclusion, we found that the bony pelvis plays an important role in the mechanics of childbirth. Therefore, future biomechanical modeling should include the bony constraint. The incorporation of the full pelvis gave rise to a higher force required for delivery and significantly different fetal head motion for gynaecoid, anthropoid, and android pelvis. The presence of a platypyloid pelvis only changed the fetal head motion slightly. In the future, to make this childbirth framework more realistic and suitable as an educational and diagnostic tool, more pelvic floor structures, including the perineal body, the one in gray, and external sphincter, the structure in green, will be incorporated to provide a more complete caudal constraint. Thanks for your attention.
Thank you for that excellent presentation, excellent work. This paper is now open for questions.
Beth
Please.
Shelley, physiotherapist from the U.S. I wonder if you have considered including the movement of the pubic symphysis during the delivery.
When the model is complete, we will include that, because at the moment, the way we model the bony pelvis is that it is modeled as a linear elastic material, so it has a very small deformation. But if the force is large enough, if the force from the fetal head is large enough, it will push the pubic symphysis.
Okay, thank you.
Can I ask you or your clinical colleagues how feasible you think it would be to identify the android pelvis in clinical practice?
You mean in clinical practice?
Yep.
From the textbook, what we can see is that the ladies with a very typical android pelvis normally have a very specific physique, so you can identify them from the way they look, and also by visual inspection, and also by using your fingers, you can briefly tell where the ischial spines are, because the android pelvis also has a very prominent ischial spine.
I don't know what the obstetricians feel, but certainly in our country some years ago pelvimetry was abandoned, something I must admit I never quite agreed with, because in some people who have a narrow, maybe an android-type pelvis...
So how we identify the android pelvis is that we have access to MRI, so we digitize the bony pelvis, and we also calculate the distance between the ischial spine and the distance between the bottom of the pubic arch. We calculate the ratio between them and also the subpubic angle. That's how we identify a very typical android pelvis.
Hi, you've done some beautiful work, and it looks like you're set up, and I wonder whether the next step might be to do a finite element analysis to really calculate the actual stresses and strains, on the head, for example, of the fetus. So
this is a finite element modeling. So we have calculated the stress and strain distribution, but to make this presentation a bit more clear, I just didn't show it in my results.
Thanks, Peter Dietz from Sydney. Bob, I've got a comment to what you said. The one parameter that's easy to get at is the subpubic arch angle. Mm-hmm. And Stefan Albrecht from Mainz has done 2 studies in 2 different populations to look at that as a predictor. And it didn't predict anything much at all. It didn't predict delivery mode, and it didn't predict trauma to the perineum or to the levator ani either. So there are clear limitations in a Western population with good nutritional status. It may be very different in Africa. As regards the model, what I really wanted to say is the problem with models always is that you've got to test them against reality. And one of the things that I really wonder, and I think obstetricians in the audience can will easily see the point. Your forces are so incredibly low. Consider 10 newtons maximum. That's the force that is exerted by a 1 kilo weight. The gravity it's so little. If it was like that, then the babies would fall out because they weigh 3-point-something kilos. You see, I cannot possibly believe that the forces required to get a baby through the birth canal are anywhere near what you showed. I would imagine that they are 5 to 10 times higher and maybe higher than that. And I wonder whether one of the issues is that in your pelvic floor model, I've pointed that out several years ago, in your pelvic floor model, the levator is not connected to the inferior pubic ramus. So it's not connected.
So which 2 structures were not connected? Can you please repeat that?
The inferior aspects of your pelvic floor model, of your levator ani model, do not seem to be connected to the inferior pubic ramus.
So that's one of our future work, to include the external sphincter as more caudal constraint. So if the external sphincter is present, then that would provide a more complete caudal constraint. Hopefully that answers your question. And for your concerns of the force production, we did notice that the model prediction, the forces that our model predicted, were significantly lower than what we have observed. And we think what is accounted for that is the lack of intra-abdominal pressure, and also because we got this from a tongue skeletal muscle behavior. So the muscle behavior may not be exactly represent the pelvic floor muscle behavior. So what we need to do in the future is to conduct our own experiments to find out the mechanical behavior of the pelvic floor muscles, and also the incorporation of the perineal body and the external sphincter would also increase the force required for delivery.
Last question, please.
First, I have got a comment. If you go back to anatomical books, go back to the...
Can I go back to my slides?
No. If you go back to anatomical books, it's a well-known occipito-pelvic disproportions. The gynaecoid pelvis is not only the subpubic arch. It's a lot of other parameters that it will differentiate the android from the gynaecoid pelvis. It's not only the subpubic arch. And the question is that, did you have any data regarding the height of the individual or the type of the pelvis? Because it is said that in short stature females, the pelvis outlet is very small, and they end with cesarean sections, most of them, and they need more power for delivery.
So may I repeat your question? So your question is, do I have other parameters to identify different types of pelvis? Is that right?
Regarding to the height of the patient. Length, height.
Right, okay. So the reason why I only point out the subpubic angle is that it's very easy to see in my slides, and we do consider that as a very important parameter which affects the mother's performance in childbirth. But we also take into account if the pubic side wall is straight. So what we calculated is the distance between the ischial spine and the distance between the bottom of the pubic arch. So we calculate the ratio between them and to work out if the side wall is convergent or divergent. So that's another parameter we have taken into account. And also, we also look at the anterior-posterior diameter, which measures from the base of the coccyx to the center point of the pubic symphysis, as well as the subpubic angle.
I think this is complementary to the previous research that it should have been taken into consideration, this data, on the first one.
Thank you. Dr. Yan, thank you very much indeed for excellent presentation. Thank you.
Thank you.